Okay, I'd like to introduce today's speaker, Scott Goodspeed. Scott is the Principal and Vice President of iVantage Health Analytics in Portland, Maine. Scott has been President and CEO of 4 hospitals in 3 different states. He has a deep industry experience and national reputation in governance. He is a nationally recognized speaker who has authored and delivered over 100 presentations to various professional associations and healthcare organizations. Scott has published books and articles on the topics of governance, balanced scorecards, and strategy. Scott is a member of the University of Minnesota Alumni Association and a senior fellow of the American Leadership Forum. He has served on over 20 boards of directors. Scott received his doctorate in health administration and leadership from the Medical University of South Carolina. His dissertation was titled The Balanced Scorecard, Translating Strategy into Action. His master's degree in hospital administration was received from the University of Minnesota, and he received his bachelor's degree in administration of healthcare services from Ithaca College in New York. So now I'll turn it over to Scott to share his presentation on linking strategy to operations to achieve great results.
Hey, Leslie, thank you. And hello, everyone, and thanks for attending. One of the things that you may not know about me is that I chair the Thought Leadership Work Group for iVantage Health Analytics, and in the last 9 months, we actually rated and ranked 4,600 hospitals across the United States, and currently I'm doing some research with some others looking at the top 200 hospitals across the United States. Within the top 200, that includes critical access hospitals and small rural community hospitals and PPS hospitals, and one of the things we're asking them in a survey is, in fact, how do you link strategy to operations? As importantly, we're asking kind of what drives great performance, and one of the things they do talk about is linking strategy to operations. But there are 5 things that we're beginning to find. Looks like some commonality, and I'll have a book that's coming out probably late fall, early winter about this. But here are the 5 things that we're finding. And this may change as we get into more of the research, but basically what we're hearing back from these top 200 hospitals is one, they have a strategy, okay, but 2, they have a strategy that's clearly articulated. So that's the first bucket, if you will. 2, they communicate the strategy broadly. When they say broadly, it's at the employee level, and typically the communication isn't from executive management team, CEO. Oftentimes it's department director, supervisor, or it's peer-to-peer presentation. The third thing that we're hearing in terms of linking strategy to operations is they build accountability for results, and they do that through meeting, and they do that through what they're calling reframing how somebody thinks about their job. So it's not a job title, but it's kind of reframed in the context of the organization's strategic plan. So the fourth thing that we're finding is they measure everything. Okay, they use analytics, they use indicators, they use metrics, whatever you want to call it. And then number 5 is they monitor and report everything related to strategy. So those are the things we're going to talk about today as we go through this. Some of you have, if you were on the call last week, you may have seen a couple of these slides. This presentation is meant to be somewhat interactive, a little bit fun, but given it's a webinar, that may be difficult. So as I ask questions, you may hear me answering my own question just to move it along. So with that context and that research, let's get into this. I'm not going to go through the table of contents, but this is basically what I'm going to cover over the next probably 50 to 55 minutes. I'll leave some time for questions, or if you have questions as we go, I'm more than happy to answer those. As I travel across the United States, and I'll be in Rochester, New York tomorrow, meeting with a group of hospitals, the kinds of things that I'm hearing is that income is down, the cushion is lost, a lot of confusion about accountable care organizations, especially for critical access hospitals and small rural community hospitals. And then, in fact, what's the impact of healthcare reform on our patients, on our community, on the quality that we offer and provide, on our financial statements. But I'm also hearing across the United States, hospitals are very interested in strategy, putting the stake in the ground in terms of where they're going to be over the next 3 to 4 years, and pursuing that aggressively in the face of all the conversation or dialogue about healthcare reform. So we work with, it's actually over 750 hospitals across the United States on GIS mapping, some benchmarking tools. And I'm one of the few in the firm that actually provides analytics, but also does some advisory work. So here's the problem with strategy execution and linking strategy to operations. If you look at the bottom quote from Fortune magazine, and this goes back to 1999, he says, in the majority of cases, we estimate 70% of the real problem isn't bad strategy, it's bad execution. When I did my doctoral dissertation at the Medical University of South Carolina, I replicated a lot of the studies going back about 5 years ago. And the percentage of bad execution that I found in healthcare across the United States was about 50%, and we'll talk about some of the reasons for that. The other problem is that in this Codnos joint study in 2006, and then it was updated in 2010, found that only 12% of companies successfully execute their strategy, and there's the same level of concern in healthcare. But here is some research that I conducted in 1999 for Modern Healthcare and the Governance Institute, and I received about a $25,000 grant to do the research. I ended up writing a book for American Hospital Press, but when we surveyed every hospital across the United States, their board chairs and the CEOs, we actually got a pretty good response rate. I think there was about 6,000 hospitals at the time, and I had 1,841 responses from board chairs as well as CEOs across the United States. And when I asked my research assistant to cull down all of the data and the research findings, the survey related questions that we had, tell me what this means from a CEO perspective, because I was running a hospital at the time, and she came back and she said, well, it means 4 things. Those 52 hospitals we found in the research that seem to outperform others and drive performance are very clear about 4 things. One, they're clear about kind of they asked the question, where are we today? What's the current reality? What's the market look like? What's the relationship with the medical staff? What's the relationship with the board? The second question they ask is where should we be tomorrow? So that's the vision piece. Third, they ask the question, how shall we get there together? That relates to capital budgets and resource allocation. And then the fourth question they asked is, in fact, are they getting there? And that's the performance monitoring. When we updated the research in 2005 for these 52 hospitals, there's one additional thing that we found, and that was driving performance, and that relates to the question is, does our culture support strategy? Now, I'm not going to talk about cultures that support or drive strategy, but basically there are three kinds of cultures that we found in these organizations, and anyone that wants additional information, I can send that to you all through Leslie. So while that research was 1999 and 2005, again, we're looking at the top 200 hospitals, performing hospitals across the United States, and doing similar kinds of research. But this is what we know today about those 200 hospitals in terms of what creates a strong hospital, and there are basically three components to the formula. One relates to the organization's market. The second characteristic relates to value-based performance, quality, outcomes, a whole bunch of metrics. And then the third characteristic is finance. But typically what we find in these strong hospitals, if you will, is they have dominant market share, Medicare, all-payer, with growing demand. So when we look at the demand in their primary, secondary, and perhaps a targeted service area over a 5-year period of time, they're seeing growth. They have diffuse competition, meaning that there's not a lot of competition, hospitals or physicians within their primary or secondary service area. The third thing that characteristic we find is outstanding quality and safety programs, oftentimes is measured through HCAHPS, core measures, as well as the ARC quality criteria. On the finance side, strong hospital in this definition, high margin services, strong balance sheet, so of course strong income statement and balance sheet, but also efficient and appropriately priced services as they begin to think through and prepare for healthcare reform. Here are the objectives of the strategy-focused organizations or strategy-focused hospitals, and here are some of the things that they think about. First, they have a framework for how they design and how they talk about their vision and strategy. Some hospitals use the Studer Group methodology, some use strategic themes, some use a framework which they're familiar with and they've been using for years. But they also use that framework of that methodology to make sure that everyone understands the strategy and there's good alignment. 3, they create strategic measures. Everybody in the organization understands those metrics and measures. They also have a system to evaluate and set priorities around strategic initiatives. So they're able to set priorities with limited resources, and they can say to the medical staff, executive committee, board of trustees, and the executive team, as well as the community, here are the 5 things that we thought about this year. Here are the 4 that we're doing, and here are the reasons we're doing it, and here's how it fits strategically. And then the other thing, which is interesting to me, is they institutionalize a language. So if you were to visit one of these community hospitals and you talk to Nancy in Food and Nutrition Services and said, Nancy, tell me about the organization's vision. Tell me about the objectives that they link to that vision. Tell me about the metrics. They actually have a defined way of communication about strategy that is shared broadly, but it's also known broadly throughout the organization. And it's more than just rote, if you will. Here's some of the terminology that I hear more often than not, and it relates to, and I'll start with strategic themes. It could be the Studer pillars. But when you talk to these CEOs and board members and physicians and say, tell me what's important in the organization, they'll say, Scott, what's strategically relevant is quality and patient care. Okay, what's strategically relevant is the financial health and growth of our organization. And that's articulated throughout the organization. The second thing that they talk about is objectives, and basically they will say it's an action-oriented goal that states where we want to be or what the activity is over the next, typically it's 9 to 12 months. And everybody understands what an objective is. Third, they talk about indicators or metrics. So they talk about very specific performance measures that they link to the objectives that link to the strategy. The next thing they talk about is targets. So if you talk to a nursing supervisor and ask about, tell me about the core measures for pneumonia, for heart failure, the skip measures, and tell me what the target is in the organization. And these organizations that focus on strategy will say in a very predictable way, it's all or nothing. It's what Don Berwick says, so it's 100%. When you ask them about, tell me about the organization's net income, where it is today on, let's say, a month or year-to-date basis, but what's the target in the budget, they can tell you that. And then oftentimes they will publish how well they're doing with some very commonly available, publicly available benchmarks. So they have a systematic way of talking about strategy within the organization. And this is just my perspective on how strategy has evolved in rural hospitals over the last 6 years since I've been working with small hospitals. Early on, there were lots of discussion about the balanced scorecard used in that to drive strategy. I'd say the last 3 years, there's greater articulation about a strategic management system. And then in the last, I'd say, 9 to 12 months, a lot of conversation about this thing called a strategy-focused organization, and I'll show you the components of that and what, in fact, that means. But the other thing that we have learned about talking with these strategy-focused organizations is when you talk to board members, they understand what the board strategic planning framework is, and this is a framework that came from a number of small community hospitals where the board on an annual basis will begin to think through vision, mission, values, which you see here. They overlay that with what they call the discipline analysis. So they want to know what are the strengths, what are the weaknesses in the marketplace, what's going on in the marketplace, what's the population doing, is it flat to down. In fact, are we going to see growth in clinical service lines over the next 5 years? What's the competition? Where are we with Medicare share? And has a fairly sophisticated way of looking at the marketplace. Next, they begin to talk about what are the objectives we link to the vision, how do we measure those objectives, and then let's talk about what's the scorecard and how do we track those initiatives. And that the result of that typically is a one-page executive medical staff leadership board report where they're looking at key metrics based on the objectives that they can monitor on a monthly and a quarterly basis. I'm not going to spend a lot of time on these 5 principles of strategy-focused hospitals, but here is what they do, and I can send to Leslie a tabloid breakdown of what they do over 12 months, and it's like a CEO checkoff list, if anyone would find that helpful. But first, they have a strategy. 2, they have the ability to translate that strategy into initiatives. Number 2, executive leadership drives the strategy, where the CEO is actually the sponsor for the strategic planning initiative on an annual basis. 3, the organization understands the strategy, so that relates to organization alignment. Oftentimes, meeting structures are changed. the way presentations are made at the employee level are a little bit different than a reporting out, if you will. 3, strategy is thought of as everybody's job in the organization, so it's not just the CEO's job or the job of the executive management team. And then 4th, as organizations get into this process over 9 to 12 months, it becomes a continual process. So strategy is linked to budgets, strategy drives budgets, strategy is linked to board meetings, so those strategic themes that were discussed early on as part of the planning process form the agenda for the board meetings as well as the executive management team meetings. Here are some other characteristics of strategy-focused organizations. One is they challenge their assumptions. So I was at a small hospital in Pennsylvania about 2 years ago, and they said, Scott, we could never recruit 2 internal medicine docs. The only docs that we have on our medical staff are family practice physicians. The only reason they're here because they married their high school sweetheart and their spouse is here. And so our ability to recruit from outside the community and internal medicine physicians is not going to happen. And so we challenge that assumption. As a matter of fact, they have 3 internal medicine physicians on their medical staff now, and 2 of them are doing scopes. So it's driving a lot of the revenue. Second, they know how to get from A to B. So they know where they are, they know where they're going, but they also know how to execute strategy. Most importantly is everyone, and you can see that in capital letters, sees the same preferred future. So if you talk to the employees in these organizations, not only can they articulate where the organization is going, but they're probably going to do that over about a 25 to 30-minute time frame. So it's not the standard 3-sentence vision that you see in the boardroom or in a meeting room. It's something a little more extensive than that. So here's just a riddle. Some of you may have heard this. I'll answer the question, but the question is, the riddle is a husband and wife were born in Boston, Massachusetts. Their son was born in Boston, but the son is not a citizen of the United States. How can that be? And when we do this in a more public setting, the questions come back. Well, wait a minute, is the son born in Boston, Mass, or Boston, England? And it's Boston, Mass. Is the son adopted? Was the son brought in from another country? And the assumption that most of us have about this question is the time frame is today, when in fact the husband and wife at the time when the son were born, none of them were citizens of the United States, because this happened before the Boston was part of the United States and part of the colonies, and it happened before the Revolutionary War. So when I talked earlier about that hospital in Pennsylvania that says, in fact, we can't recruit internal medicine docs, oftentimes they challenge that assumption and reverse the assumption. The other thing that these hospitals know is they know how to get from A to B, so they're experts at strategy execution. They know where A is, they know current reality, they know what B is, so they put a stake in the ground 3 years from 4 or 5 different perspectives, from a financial perspective, from a quality perspective, from a growth perspective, from a physician relations perspective. More importantly, with that little arrow is they know how to share the strategy broadly throughout the organization, but they also know how to execute strategy. When we talk about seeing the same preferred future, I always ask the question, what do you see here? And oftentimes when you see this, and everyone has seen this, most everyone has seen this, but it depicts an older woman as well as a younger woman. And then the question is, and this is kind of fun to use with the board, here's the older woman's eye right here. Here's her nose. Here's her chin. Here's her lips. And here's the younger woman here with her eyebrow, her nose, and her chin. But the question becomes, how, in fact, can you be looking at the same reality and see two very different things? And we do that in our organizations all the time in terms of talking about the future or where the organization is going or what, in fact, is going on in reality. The next question is which one of these creatures is larger, is bigger, and in fact, if you measure them right now, they're both in fact the same size, but we can both look at the same reality and see very different things. And then some of you know that my daughter Katie has done a bunch of work in Africa, so she knows elephants. The question here is how many legs or feet on this elephant, and it's a little bit of a trick question when you look at this, and I typically hear 4, 8, 9, and 11. Once I had a pathologist at a retreat say, Scott, I can prove unequivocally how many legs or feet on that elephant. In fact, they said that's way too much for me. But the point is, if we have, let's say, 200 people in your organization looking at this picture of the elephant, and this is, in fact, how you're going to position your organization or the hospital, the only thing I want them seeing is the same number of legs. I want them to see 4, 8, or 9 and have an understanding of where the organization is going to be longer term. So here's one way of thinking about vision and or preferred future, and this makes a pretty interesting exercise at the board level with the medical staff, leadership. Oftentimes that's everyone on the medical staff, but also can be a very interesting exercise with the department directors. And this isn't the full exercise. I can send it to Leslie, and you can do this yourself. You don't need somebody like me, but there are two kinds of vision options, if you will. The first is, what's the clear bet? So if we're going to connect the dots and we look at the hospital's performance over the next 5 years, what in fact is the clear bet for our future? So we're connecting the dots. The future will look a lot or somewhat like the past. So there's a range of predictability there. There's a second kind of future, and that's a breakthrough future. And I don't mean a small community hospital that now is going to start doing invasive cardiac cath, diagnostic cath, and cardiac surgery. That's not the kind of thing I'm talking about. But if we ask the question, if we wanted to create a breakthrough future for our community hospital, what would that future look like? And if you in fact go through this exercise, it probably takes about 45 minutes of group work. Then the question becomes, which of the two futures would you choose? Oftentimes it's the clear bet. Sometimes it's the breakthrough future. Sometimes it's also a combination of the clear bet and the breakthrough future. And then the next couple of slides talk a little bit about how, in fact, you set this up in terms of, assume you get in a time machine, what will your hospital look like in 3 to 5 years? What's the clear bet? So here is an exercise you can walk through. If we talk about the breakthrough future, and we talk about a future that is discontinuous from the past, so it could be very different or different, but it can't be a pipe dream. Let's put some design criteria around that. It's got to be motivating. It's got to be doable, maybe unpredictable. It makes a difference for our community and patients. And assume you get in a time machine, what would that future look like? Now, I was in a brand new critical access hospital last week, offering the American Hospital Association quality trustee curriculum, and when I talked to the board and the executive team and the doctors who were there, one of the questions I said is you're in your new facility, they've been in it since 2007. I said, how did you see this? Or how did you come to this, and how did you know you could afford it? And they basically began to talk about, we knew we could continue what we did in the past and connect the dots, but we really wanted something different. We wanted a breakthrough future for our community, and we had a sense of what it looks like, and we wanted to be able to do it alone and independently, which we did. If we needed to do it with somebody else, we would. So that's a good example, and some of you are maybe in those new facilities today. So here's how these organizations that spend time on strategy, this is some of the language that they use, but here's where they focus their time. And what's interesting is they spend very little time talking about financially where they're going to be or where they've been, but they will tell you absolutely unequivocally, we better know the income, we better know and understand the elements of the balance sheet, because we've got to be profitable, we've got to build a balance sheet to thrive in the future. But they don't spend a lot of time talking about kind of financial outcomes. I was at a Becker's Healthcare conference last week, and a very large organization, Herman Hospital in Dallas, which is a very, very large system. The CEO spoke for about 35 minutes and talked about strategically what drives that organization. And he did not talk about the financial performance. He said that, in fact, is an outcome of what we do. And here are some of the things that I talk about, but he spoke to all of these. And so these strategy-focused organizations, first, they focus on what I call people, infrastructure, technology. So that is foundational. If we get the right people with the right skills, we give them the right tools and the right equipment with the right training in the right environment with the right technology, that's foundational to linking strategy to operations and creating a very good, if not a great, organization. Two, they focus on those clinical and business things, the processes that deliver value to patients and to providers. And then they focus on customers, and that relates to if we get the right people with the right technology, infrastructure, delivering the right kinds of processes, if you will, and I don't like that kind of term, it's a little academic, can we in fact hit the bullseye with our customers, and I define customers as patients and providers. So when you have this discussion in the boardroom, at the management level, these are the three things that you talk about, and if we focus on these things, the financial statements will follow. Now, it's not quite that easy, but I think you may understand what I'm saying. The other thing, there's often a gap between strategy and action. That gap creates the reality that oftentimes strategy doesn't get linked to operations. So organizations that are clear about mission, vision, values, and strategy, but don't take the next step, and here's what the next step looks like. It creates a implementation focus. It's clarity around initiatives. It's clarity around building accountability throughout the organization and setting personal objectives, but also over time, employees begin to rethink their job and reframe how they operate within the organization. So here's what a scorecard does. It basically helps us build a framework that helps hospitals translate the strategy into both operational objectives that drive both behavior and performance. And kind of the key here is it drives both behavior and performance. And when we talk about behavior, we talk about organization-wide behavior. So performance is consistent among and between board members, medical staff leadership, management, as well as employees, and there's consistent accountability. So if there's a executive or a physician that seems to go out of bounds with either language or anger issues, this helps create a even playing field. It's also a way of collecting data and information that helps hospitals move from kind of strategy to action, because in fact you can actually see the hospital's performance, you can see it trended, you understand what the target is, and oftentimes you have comparison information in terms of benchmarks so you can see how you're doing compared to the competition. This is what the research has shown in terms of strategy execution, and this goes back to the research that came out of Kaplan and Norton and the Harvard Business School, but essentially says that 9 out of 10 companies fail to execute strategy. Again, when I did my doctoral dissertation and replicated a lot of this in healthcare, what I found was it was more like 6.5 or 7 out of 10 hospitals failed to execute strategy. And the first reason was if only a small percentage of the workforce understands strategically where the hospital is going, how in fact are you going to get there? If only the executive team or the board or medical staff leadership understands where the organization is going, how in fact are you going to get from A to B? The other barrier is how executive teams spend their time meeting and discussing strategy, and you can see the research says that executive teams spend less than 1 hour per month discussing strategy. The third barrier is called the resource barrier, and this is where organizations don't link budgets to strategy. In fact, budgets drive budgets. So if we had a 1% net income last year, maybe we'll have a 1.1 or we'll have less than 1% net income the following year. And then finally, the fourth barrier to strategy execution relates to linked incentives to strategy. And we've got a number of small community hospitals that, in fact, have linked incentives to strategy. I can send Leslie some of the plans that you have sent to me. They usually do it. It's 1 or 2 pages. Oftentimes, it's in the form of a bonus, but you've got to hit the net income target. You've got to hit certain quality targets. There are 4 or 5 metrics, and it's again a little bit like quality, where you've got to hit all or none. But I'd be happy to send you samples of those. These are some things that oftentimes I hear from clients in terms of barriers related to linking strategy to operations, and I'll just touch on a couple of these. One of the quotes is, each year we spend 4 months preparing the plan, and somehow it always ends up the same as last year. Or as department directors and supervisors, we're not involved in strategy formulation. One of the other things that I don't hear as often today is the top one. Our leadership team doesn't make decisions; they just react to what's going on in the environment, creating frustration throughout the organization. One of the things that some of these hospitals do is they map their strategy. So on a 1 page, they talk about their financial objectives, their patient and provider objectives. They talk about internally what they need to do to meet the needs of patients and providers. And then this learning and growth is analogous to people, infrastructure, and technology. And I'm going to walk outside of healthcare just for a minute. I was on a Southwest Airlines flight about a week ago and actually saw this in action. This is from Southwest Airlines. This is their strategy map as it relates to how they turn their planes around. This could be analogous to how we turn patients around in the operating room, how we get patients through our registration system, how we get them through our pre-op system, our admitting system. And this is an example of a strategy map that Southwest Airlines has had for over 30 years now. And some of you know that if you invested $10,000 in Southwest Airlines in 1987, 30 years later, it'd be worth over $10 million. But let me just walk through this, because this is a way of thinking about strategy, but also linking strategy to operations. This, and you can see me, I'm trying to move this. That's okay. Let's start with the learning and growth down at the bottom. Right? It's actually learning. When Southwest Airlines communicates with their employees, they always talk in terms of the strategy map, and the objective here is fast ground turnaround time. So they know, in fact, if they can turn these planes around, and you can see the measurement, they measure it by how long, the length of time the airplane is on the ground, but they also look at on-time departure. So they set a target as it relates to the strategy map, and Southwest Airlines' goal is to turn their planes around 30 minutes, 90% of the time. And you can see the initial, they have a cycle time optimization initiative. And if we look at the left-hand side in terms of the strategy map, it's the responsibility of the ground crew to turn these planes around 30 minutes, 90% of the time. And in fact, if they have the ability to do that and do that, which they do, their flight will be on time at a low price because they need fewer planes. They're turning the planes around at a quick pace, and then financially they can lower their costs, increase their revenue, and that results in profitability. So one of the interesting things, about 6 months ago when I was on a Southwest flight, I was in Manchester, New Hampshire, going to Orlando. The plane came in about 5 minutes late, so I immediately got my watch out. I set it at 30 minutes, and in fact, they turned the plane around in about 24 minutes. But one observation I had is the first officer got off the plane when the plane landed and helped the ground crew load bags onto the conveyor cart to get the bags into the building. When he came up and down the stairwell, I told him I was on the next flight. I asked him, I said, do you usually help offload the bags? And he said, Scott, he said, when we were coming in, we knew that we didn't have the numbers of ground crew, so our objective is to turn this plane around 25 minutes, 95% of the time. So he actually had a different standard. But a strategy map, a component of a strategy map is a good way of communicating strategy within a healthcare organization. This is their full strategy map, and they're a billion-dollar company, but I'm not going to go through it, but it may be one of your considerations. This is a small community hospital, rural hospital in West Virginia, that said they wanted to prepare a strategy map for the strategy they had thought through with the board, medical staff, and leadership, with some employee focus groups. And you can see that they had 6 goals, very simple. First goal is they want to improve the health and well-being of the community. 2, they wanted to improve the work-life experience of their employees, understanding that if we can do that, we know if our employees come in and they've got a good work experience, a good life home experience, they'll hit the bullseye in terms of they use the Press-Ganey satisfaction scores. Third goal was improving their financial strength and you can see the rest. And then when they mapped it, here's the story of their strategy. And then this is a 25-bed critical access hospital. They're probably about $14 million in revenue. So when they share this story with the staff and the community, basically here is what they're saying. They're saying if we're going to improve the health of the county residents, and we're going to grow clinical services and provide high quality, we need to be the employer of choice for a highly productive and motivated workforce. If we in fact can do that, we can develop business growth opportunities, provide high quality. If we can in fact do that, we can achieve a long-term financial sustainability by providing the best rural health care services in a modern setting. And in fact, we can create long-term financial sustainability, and we can improve the health of the residents. Now, what you don't see here is the metrics that they've linked, and they've got about a dozen that they've linked to each of these objectives on the strategy map. It's a way of expressing strategically where the organization is going. It's a way of sharing broadly with the employees. It's a way of linking metrics or indicators to a map, and then creating a scorecard for the community as well as everybody else in the organization. The other thing that these organizations do is prior to development of the strategic plan is they compete on analytics. So they're very clear about the past trends, which you can see here. They want to know discharges by physician. They want to look at market share. And if you look at the bottom left here, it says market share estimates. These are outpatients. This actually is a small hospital that I work with in New Hampshire, and you can see outpatient X-ray and outpatient CT. Their market share is 126 and 132% respectively. My first reaction is that looks like bad data. But when we got in and looked at what was going on, in fact, this was in the northern part of the state, so they get snow, there are mountains, they get seasonal traffic there, and a lot of orthopedic issues and problems. So one of the things that they ended up doing was to bring in a group of orthopedic surgeons who like to vacation in this community, and so they were preeminent in orthopedics during the ski season because they had doctors coming in from Mass General, and that's just a little of what the data shows that maybe is not recognizable. They typically look at financial trends. There's a look at utilization, inpatient market share, as well as outpatient market share. And you can see, again, these are real numbers here. And again, the upper right-hand side, you can see CT utilization greater than 100% share. And in fact, that was because of the influx of the snowbirds, if you will. They look at discharges by product line. They look at share of medicine versus surgery. The interesting thing in this community hospital is you can see the medical share is in green, surgical share is in orange, and if you go to the left-hand side, the community hospital that I'm thinking about, they had about a 46% share of medicine, but less than 20% share of surgery, and that indicated, one, they weren't as strong as medicine and surgery, but two, there may be an opportunity to build their share of surgery in an outpatient so it's comparable to medical share. These hospitals also, as I mentioned early on, look 5 years out for growth opportunities on the inpatient and the outpatient side. And then once strategically they're done with that process, they begin to think through how do we link what we just talked about in terms of our long-term strategy to metrics and more tactical planning. So on the left-hand side, we've got the longer-term. Typically, it's a 3-year view where we've got vision, mission, strategic themes. Begin to have a listing of the objectives in the strategic plan. We know how we're going to measure it. And then short-term, so it's typically month-to-month, maximum at a quarterly basis. Let's begin to set targets. Let's begin to think through what are the initiatives, what are the milestones, who's accountable, and that typically is one name. And then what are the resources that we need, in fact, to link to implementation of those initiatives so it's well thought out. Here's another way of thinking of it, and this is a hospital in Pennsylvania that is about a 50-bed community hospital. One of their objectives in their strategic plan was they needed to grow through high-margin services. They were going to measure it through new net revenue. The target was $1 million. Initially, they discussed adding 1 or 2 additional family practice docs who potentially could do procedures. When they did their due diligence on that initiative, it didn't come close to $1 million. When they looked at the doability or feasibility of bringing in, and this is the story I told earlier, 2 internal medicine physicians who are subspecialty trained in GI to put in a community that was about 14 or 15 miles north of them. The community was growing double digit. There was a female family practice doc who was there on a part-time basis that the other hospital had put there. In fact, when they ran the numbers, including all of the ancillaries, it was more than $1 million hit for them. So one of the things they begin to think through is what's the objective, what's the measure, what's the target, and at the executive team level, what's the initiative? And they came up with 3 or 4, but it wasn't until the 5th one that they came up with, which was the internal medicine initiative. Another way of looking at this is one of the objectives in their strategic plan was to exceed patient expectations, and they measured that through a patient satisfaction index score. They said the target was the 95th percentile compared to other hospitals in the United States. They came up with 4 or 5 initiatives. They said, boy, we're probably not going to hit the 95th percentile. 5th time around, they came up with an initiative that was, let's develop performance behavior standards linked to the values of the organization. Let's launch those peer-to-peer. So there's peer-to-peer learning. I don't quite mean it like this, but we'll have a requirement, in fact, that the providers and members of the active medical staff and others, in fact, have to behave consistent with the performance behavior standards, or they won't even be eligible for an application for privileges to be on the medical staff. And in fact, it was about a 14 or 15-month time, they were a little bit over the 95th percentile. I'm going to talk about a couple other things. I'm watching the time. Cascading is a way of thinking through how we link strategy to operations at the individual department and employee level. So this next diagram is a little bit complex, but as you saw in that small community rural hospital, in fact, if we have a hospital strategy map, oftentimes Department A, B, C, D, E will have their own departmental strategy map where 60% of their objectives are linked to the hospital hospital strategic plan. So 60% of their metrics are hospital-based, and then 40% of the time they have their own custom metrics that are unique to radiology, the emergency department, or a nursing area. And this is a way of pictorially showing, but more importantly describing how we get others involved in the organization and link to the hospital's strategy. And the benefits that we hear from the field is better alignment, simplification, better accountability because of the measurement system, and we have better comparative information. The other thing that we see in terms of linking strategy to operations is board and management meetings change over time, typically 4 to 6 months after the adoption of a hospital strategic plan. So if you look at the left-hand side here, prior to the adoption of the strategic plan, boards, in this case, executive teams, may spend 25 to 30% of their time on strategy, most of the time talking about past performance, financial performance, reporting out, here's what happened last month, with a little discussion about the implications. But when they begin to do this in a little more effective way, in the boardroom, 65 to 70% of the time is discussing strategy. 25% of the time is discussing the implications, and very little time is spent on past review. Not meaning that a past performance, not meaning that financial statements aren't important. Those are distributed, and they're typically approved in a consent agenda format, which many of you probably do anyway. So kind of the framework provides a link between strategy and the budget, helps with execution of strategy, and again, as you can see down the bottom, an organization strategy is only as good as the organization's ability to execute strategy. We can find barriers at the board level because there's either misunderstanding or there are two components of the board that see a different preferred future. There can be barriers at the executive management team level because of a preferred relationship with another community hospital. And then there can always be barriers at the employee level because of a lack of understanding, misunderstanding, or just viewing what they do day in and day out as a job and just coming to work. To talk a little bit about the Board of Trustees, it's their responsibility to adopt the strategic plan. They provide financial oversight. They provide monitoring of the strategic plan, which is done through the executive management team, and their job at the end of the day is to recruit and advise the CEO. It's management's job, our job, to make sure that they've got the right strategic information that goes to the board. So in fact, they're focused on strategy and they're not focused on operational minutia. These are some of the lessons learned from kind of CEOs in the field. This is more about blocking and tackling, being consistent with an organization discussion and strategy over time, bringing metrics in, understanding what the targets are, making them realistic but stretch. And then one of the things, some of the benefits that we find in terms of a focus on strategy is it helps employees work in a coordinated, more collaborative fashion. And in fact, we see those organization silos, for example, perhaps between radiology and the ED, begin to collapse because there's more focus on patient care, delivery of care, continuum of care as it relates to certain metrics, and less thinking of what goes on exclusively or individually in my hospital department. It improves management communication and effectiveness because there's a broad sharing of the strategic plan throughout the organization. And then this is very difficult to see, but I talked about kind of the 5 things that strategy-focused hospitals do, so I'm not going to walk through that. And again, I tried to keep this to about an hour. I think that worked pretty well last week. With that, I'd be happy to answer questions or take comments from any of the participants.
And just a reminder to unmute your line at *# on your phone.
I promise I won't let the silence go until 2 o'clock. Because I actually have to be at a plane in Boston. But any questions or comments or thoughts? Again, if you want follow-up information or material, we had a WebEx last year and hired some and distributed templates as it relates to a strategic plan, a market assessment, some other things, and we'd be happy to send that out if you'd like. But any comments or thoughts or questions?
Good afternoon, Mike Budnick, Franklin Hospital in Benton, Illinois.
Hi, Mike.
You talk about the importance of strategy and not being controlled by the budget. We're a small hospital, critical access hospital here in Southern Illinois with a terrible payer mix and unemployment and various issues that many others, of course, around the state and around the country face as well.
Right.
What happens if you just don't have the dollars or to be able to have the resources to be able to do that? And we have a lot of things that we would like to do. We recognize as the facilities needs in the community that we have to continue to reach out, look at community health, take other initiatives. But when you're running deficits year after year, you're working hard to reduce expenses, to be able to match up and at least have a close to a break even or perhaps even a small income. How do you find the dollars and resources to do that in a small hospital to be able to build strictly, or not strictly, but build more on focus than controlled by the budget?
Yeah, I mean, great question, and that's a reality. A couple of comments. One is, and the first one won't make anybody feel better, but I've done some work in Illinois, and there are some states across the United States with the critical access hospitals. New York is a good example. Ohio, we do a lot of work where they have good commercial contracts, other payer contracts, and in fact, they can do well financially. There are other states, Hawaii is a good example. Every critical access hospital, if not every hospital, including PPS hospitals, work in a deficit. Okay, so that's just, depending on the state you're in, it's either good or bad news. That's number one. Two, strategically, what I see, and this may or may not be relevant, Mike, to your marketplace, but here's what I see. Critical access hospitals that are, let's say, break even, a little bit of a loss, break even year after year. So, still sustaining their performance, remaining independent, will oftentimes look at clinical affiliation opportunities. So how many providers do you have on your staff?
We have 12.
12. So primary care and maybe a mix of some specialty docs?
One general surgeon, the rest are all either mid-levels or primary care physicians. But we're a county 35,000, 40,000 people, and our out-migration is probably 80%.